To call upon Dr. Pooja KHAMAR. She's going to speak about a very interesting concept of how do you do a corneal modulating the TGF beta pathways in new frontiers in corneal wound healing and scar modulation. Dr. Pooja.
Thank you, and I would like to thank Dr. Rohit and the entire AIOS committee for giving me this opportunity. So as we all know, corneal scars or corneal haze can be like a that dreadful complication for any of us to present. And when it comes to managing a corneal scar, it's quite difficult because it's not just one etiology or pathogenesis involved. Your corneal haze or scar can be because of many reasons, which can be PRK, because of chemical injury, keratitis scar, inferior graft edema, many things. So you have to first identify what etiology your scar or haze is because of, and then go ahead with it. So usually, whenever there's a normal wound healing response, there is always some amount of TNF-alpha and other inflammatory markers which are involved in a normal wound healing. They activate your keratocytes after any injury or any scar. Those keratocytes gets converted to myofibroblasts, and then this myofibroblasts, they kind of apoptotize because of various markers being generated in the eye, and it kind of dissects your aberrant collagen, and that's what leads to a normal wound healing. These are how your keratocytes look like. You can the less the white the body is, that means lesser activation. This is what will happen after your PRK or any injury, the myofibroblast conversion. They get apoptotized, and that's when the normal wound healing comes. But when this balance of the inflammation and anything is broken, whenever there's a higher amount of TNF-alpha or any inflammation, then that's when it will lead to abnormal wound healing with higher amount of myofibroblast not getting dissected or cut with the genes present in it. That's when it leads to aberrant collagen formation, and that's what leads to formation of haze. I'm trying to simplify it much in a simplified way so that all of us clinicians understand. So let's see this case example. This is a lady who came for refractive surgery. Everything looked fine. The dry examination is normal. The topography showed a corneal thickness of 480 and 475, so it was a little bit on the borderline side. So we decided to go ahead and do a trans-PRK surgery for this patient. However, 6 months post-operatively, this patient developed haze. And this is what the densitometry looked like, more at the 3 and 9 o'clock position, because we had done a cylindrical correction for this patient. And we treated the patient with steroids, immunomodulators, and tacrolimus eye ointment, but the haze did not come down. It was more of a late onset haze. So we decided to go back and look into what were we missing. So we've developed this BioM Pathfinder kit, where in my own clinic or any one of your clinic, you can measure all the biomarkers in just 90 minutes like a hemogram report. You do a tear test with a Schirmer's like how you do it in any normal clinic. And without discarding the Schirmer strip, you collect it in an Eppendorf tube. And then you add a patented buffer solution which comes with it, and then you shake the tube for 5 minutes so that all the proteins gets extracted in the tube. And then at the end of 5 minutes, you take the solution and put it in the cartridge. At the end of 90 minutes, you'll get this report like a hemogram report, where there's a detail of every eye, right and left eye, the level of biomarkers present, the inflammatory, non-inflammatory, whether they are normal and abnormal. And based on that, you can find out whether there's a healthy eye, whether there's subclinical inflammation present, or whether there is inflammation present. And based on that, you can devise a treatment for this patient in a customized way. Now, our patient, we had stored tears for this patient, and our patient had higher levels of TNF-alpha present to begin with. Now, why is TNF-alpha or other inflammatory markers of reason? Whenever the TNF-alpha is on the higher side, it kind of imbalances the healing of any post-surgical procedure or any scar or anything, and there's a lot of pro-inflammatory cascade going on. And whenever there's a lot of pro-inflammatory cascade going on, the TGF-beta molecules goes on the higher side, and that's what leads to haze, and that is what happens in any patient. So you have to take care of TNF-alpha. Now anyone will ask me, TGF-1-beta is normal, right? It has to be present for healing. Yes, TGF-beta is a double-edged sword. Any amount of normal TGF-beta leads to a normal wound healing process, but any amount of higher TNF-alpha leads to higher TGF-beta production, leads to abnormal wound healing, and that's what leads to haze or a scar formation. Now, we have to look at medications. None of this worked on a patient. So but for the past few months or years, we've been listening about losartan. Now, what does losartan does? It suppresses the TGF-beta activity, scarring of the wounded corneal stroma with inhibition of extracellular signaling, regulated kinase-mediated signal transduction. Now, what's that? Quite complicated, right? So to simplify it, what losartan does is, losartan tries to start breaking this myofibroblast. Those white bodies which you saw on a confocal, the losartan starts killing them, and that's when it leads to inhibition of fibroblast formation. That's how it starts cutting your scar tissue, and that is what happens. So before doing any studies on patients, we did some cell line studies, and what we saw was that when TGF-beta means there is a scar, whenever you add a losartan on this scar tissue, the scarring starts coming down, which you can see on this alpha SMA and vimectin, and also the collagen which is leading to scar formation also starts coming down. So we used losartan 4 times a day for these patients, and it's a slow going process, but you can see the haze is coming down, and after a total of 6 months, the haze was finally 10%, it came down by 90%, so the losartan was working. Now, we did do a recorrection for this patient for scar removal, but it didn't help, so we did not have one more choice of doing a recorrection, and that's when we went to losartan eye drops. Now, we've used losartan eye drops for corneal scar patients as well. It's an ongoing work, but you can see with 1 month of treatment how the scar is coming down, and this is also one more patient where you can see the density of it is coming down with just 1 month of treatment. Now we wanted to see what's happening, like what's happening to this scar, and this slide I've borrowed from Dr. Rohit, and my colleague Deepti helped me make it. You can see there's a lot of traction line scenes due to contraction towards the area of fibrosis. So that's what is kind of leading to the hyperopic shift in this patient. And when we started using losartan, not just a scar density reduced the contraction bands towards the area of fibrosis, but when you see this confocal images, you can see there's a highly dense area here, and this is what the myofibroblasts and fibroblasts look like. And when we use losartan, you can see it's cutting down those fibroblastic tissues, and that's how the haze is coming down, and that is what you see. Now, scar formation is not just TGF-beta driven. It can be because of abnormal angiogenesis, keratocyte proliferation, and epigenetic dysregulation or immune cells and factors. And it's not just one therapy which looks like it. We have to look at gene therapy, amniotic membrane therapies, or limbal stem cell transplant as well, and newer topical drops to make it simplified to treat these drugs. So one of the drugs which will help us will be a potential for a ROCK inhibitor to treat the corneal fibrosis, because substance P induces fibrotic changes via the ROCK pathway, and if you use a ROCK inhibitor, it can help us in reducing the fibrosis. We are also looking at SAHA-based drops to reduce the scarring of the corneal tissue, and if nothing works, the future would be towards the gene therapy for treating the corneal fibrosis and angiogenic related changes, where if you use a gene therapy, the scarring does come down, and this is work done on a rabbit model for corneal haze prevention. So as simple as possible, we have to come up with newer drugs to treat haze where nothing works, or your retreatments with surgery also fail. However, the future direction would be a gene therapy or a nanoparticle drug delivery or a bioengineered cornea. So to conclude, traditional therapy does have limitations in effectiveness and potential drawbacks. We have targeted non-invasive therapies which offer scar modulation and less invasiveness, but we can work on it in more numbers, and the next gen regenerative therapies would be promising advanced solution through innovations. Thank you.
Thanks, Pooja. As always, a fantastic talk. It was a very interesting topic when you started to speak about corneal scars, especially post-chemical burns. So I just had a question for you, that when you followed up these patients on, looking for factors in the corneal scarring, what was the longest follow-up in these patients that you take?
Ma'am, we've started using losartan only for 6 months now. And as you have seen in published literature, it's a slow-acting drug. So it just doesn't act right away. It takes 6 months to 1 year with these drops for the scar to come down by 90% or disappear. So the haze patient, we've given it for 6 months with 90% resolution of the scar, and the one because of the herpetic changes and the bacterial infection, the second and the third case, it's just 3 months. So it's work in progress.
Yeah, so no, the only thing which I had, probably it could be in addition to your, work, the fantastic work that you're doing, is that when we are looking at these scars, even clinically we see them shrinking over time, and it is only beyond 3 to 6 months that we either post chemical burn or a scar take a patient for corneal transplantation. So probably it will be worth, comparing these with the normative data in a patient to see how the scar modulation works. The other cohort has to be a normative data of these patients when you're comparing the ASOST pictures, especially.
Absolutely, ma'am. So one thing about losartan drops, because that is an off-label use, and what a lot of people have been trying is you can use it two ways. You can use it either for prevention of scar in PRK-Hayes patients, but if you have a post-infection scar or a post-chemical injury scar, or you have a scar because of post-PRK which is not resolving beyond 6 months to 1 year, that's when you start losartan.
Yeah.
You don't start losartan right away.
Yeah, I think that's the take-home message from her talk, that probably after 3 to 6 months, if you are not seeing it, probably that is the drug to
Yes,
go for.
ma'am.
Thanks, Pooja, for a fantastic
One comment,
talk.
Pooja, just,
Yes.
yeah, so what about the vascularized scar? In the eyes which have, say, for example, a HSV keratitis, we have a large blood vessel often coming, and whatever studies we have seen about mice and, therapy for, fine needle diathermy, where once you occlude the blood vessel, what has been noted, the scar shrinks on its own. Okay, so now when we are like you elucidated that slide where you have looked at the various other factors which are responsible. So do you think therapies like losartan can go in conjunction with such therapies, whereas you do a fine needle diathermy and also use, are those, my question is that are those HSV kind of scars or the ones with the vascularized scars also a candidate for losartan therapy?
I would say
Sorry.
yes, but it has to be a conjunct therapy, as you mentioned, because you have to treat the root cause first, and then because of the root cause there is a scar, you need adjuvant therapy to reduce the scar. So if there is a neovascularization, mice is something which we saw in World Cornea Congress, which is catching up. I think that would be one of the treatment modality, but when you use mice like of a treatment, we've not had personal experience. The neovascularization reduces some amount of scarring, but not entirely. So I think you have to use losartan or maybe one of these anti-scarring drops, TGF-beta driven drops, along with a mice therapy.
So
There is an adjunct therapy. It's never one thing.
Thank
and
you.
you also have to personalize. Like you saw, that scar can be because of various pathologies. So you have to, losartan is not going to work for all the patients, but specific ones.
Yes, thank you.
It's not related to the chemical injury. It's if you have got basically a congenital limbal dermite, which is involving the visual axis, and the treatment modality is a surgical, which is both visual and cosmetic. And the various modalities are lamellar autograft, stem cell graft, abdominal graft, and the latest is smile lenticule tattooing. Does these drops have a role to reduce the corneal scarring? I have seen some cases of gold Harer syndrome, where there's a congenital limbal dermite with associated preauricular skin tiger appendage and others. The question is that if you've got a grade 1 limbal dermite, you do observation and counseling. But if the limbal dermite involves the visual axis to threaten the vision, does these drops have, because when you excise the limbal dermite, there is a scarring. Then you tattoo it. Then you put a corneal lenticule. Does these drops have a role in that?
So no personal experience. Based on the pathogenesis of how the drugs work, yes, but we will have to look into this.
Actually, in connection with this, Pooja, I wanted to ask you also.
Yes,
You partially answered it, but at what stage of the scar formation that you would advise these drops? So, like what sir is mentioning, will the drug act at established scars, or will it act at the newer scars which is just forming? If you have a scar, say 10-15 years old scar, will it work on these scars?
No, ma'am. So
at what stage will it work?
Recently established scars, which are within probably 1 year, these drops will work well. But if it's a 10 or 15-year-old scar, like how sir is saying, it may not work, because this drop works on cutting down your myofibroblast and fibroblast activity, and which is within 1 year of your scar formation. But long term, this drug has not known to have its use, but again, we have to use it on a larger scale to see
They
if
say
it will
that
work or not.
when you excite the limbal dermoid which involved visual axis to get that, I mean, sort of cosmetic, you do a tattoo, then you put a corneal lenticule upon it. This modern of surgery is thought to be a better option because post-operative astigmatism and the pain is less because don't put any sutures. Over the past about 8 years, I have seen about 8 cases of gold heart syndrome, and I'm a little bit of
Yeah. I think in the interest of time, we'll
Yeah.
move on to the next talk. This is a very exciting discussion. Thank you, Dr.
Thank
Pooja.
you. Thank you.